Good morning, everyone. My name is Abdul Azad. Welcome to today's webinar. I will be your host for next 1 hour. I'm a postdoctoral lecturer and researcher at Athena Institute here in Vrije University, Amsterdam. I'm one of the team members of AHEAD. Our project, Action for Health and Equity Addressing Medical Deserts, or AHEAD in short, aims to reduce health inequalities by addressing the challenges of medical deserts and medical desertification in Europe. Our team consists of Center for Health Policies and Services Romania, Cittadinanzattiva Italy, Media Education Center Serbia, the National School for Public Health Management Moldova, Wemos is our lead partner organization, and Athena Institute at Vrije University Amsterdam. Before I begin the webinar, let me share a few housekeeping rules for today. This webinar is being recorded, as you know, and the recorded video will be available at our website, www.ahead.health. And the link will be shared via our social media handles, including our Twitter handle at ahead_EU project. We welcome you to share your comments and thoughts, questions during the webinar. Please use chat box. My colleague Pearl will be keeping an eye on your questions, and we'll take this up during Q&A session. Our project aims to reduce health inequalities by addressing phenomenon of medical desertification in Europe. A single stakeholder cannot address or solve this problem of medical desertification. This is a huge problem, and it requires a complex participatory decision-making process. And to do that, we are deploying participatory consensus-building methodology. To share more about consensus-building methodology, today we have Jessica. Jessica is a PhD candidate with Athena. Her research investigates inclusive healthcare. Welcome, Jess. Please go ahead with your presentation.
Thank you, Abdul, and good morning, everyone. Thank you for being here. Pearl, if you don't mind sharing the slides. Yeah, so as Abdul mentioned, I am a PhD candidate at the Athena Institute in Amsterdam. And I was a part of the team who helped develop these consensus building methods. This was a collaborative effort between ourselves, all of the consortium partners, as well as the facilitators who actually helped execute these sessions. So also a thank you to them for their participation and their assistance in this. So today I'm going to very briefly talk to you about consensus building methods, what they are, and what consensus building in the context of the AHEAD project means. Pearl, if you could go to the next slide, please. Perfect, thank you so much. So I think it's important to start by just very briefly clarifying what a medical desert is and how we, in the context of the AHEAD project, see medical deserts. So essentially, a medical desert is an area that is isolated or depopulated, where there are significant falling numbers of health practitioners and overall health workforce shortages. So in short, there are not enough healthcare workers for the amount of population within a certain locality. The thing about medical deserts is that they are extremely complex societal problems because they have many different layers, many different facets, and they affect diverse groups of people with different interests in the issue. And the thing about complex social problems is that there are often no quick fixes or a one-size-fits-all solution. And this is also true for medical deserts. So what this requires is that decision-making also is a complex process that needs to consider many people's opinions, many people's experiences, as well as many people's expertise. And as Abdul mentioned, we wholeheartedly believe that a single government body cannot solve medical deserts on their own. It is something that requires multi-stakeholder involvement in decision-making. Next slide, please. Thank you. So What is consensus building? So essentially, consensus building is a social process where you try and obtain a general agreement amongst stakeholders on a policy option, in our case, to counteract and prevent medical deserts. What's really important to understand about consensus building is that to us, it doesn't necessarily mean that all stakeholders have to agree with each other in all respects. We very strongly believe in the ability to agree to disagree, or to come to some kind of common understanding, or at least some sort of partial agreement. It doesn't require everyone agree situation in order to be deemed valid. It can be a majority decision. As the AHEAD Consortium, we focus on building consensus on policy options that try to focus on a wide range of, very importantly, locally developed innovative solutions. We believe very strongly that in the AHEAD project, the only solutions that we feel can really have weight are those that are locally developed from the perspectives of multiple stakeholders. And that is what we've been trying to do in this project. And as a result, we expect that participatory consensus building processes can lead to better decision making by involving different stakeholders in developing better solutions. Next, please. So consensus building has a few underpinnings as to why it is something that we decided would be a good fit. The first issue is that consensus building really focuses on the idea of equality and equity, because these policies are co-created. And because they are co-created, they are more likely to address health inequalities, because you really take into consideration the perspectives of those who are most impacted. Consensus building can also increase quality, as these policy options are likely to be more locally relevant. Again, I say locally relevant because that's something that was really important to us, is making sure that the options that we presented and the options that were developed were suitable to the context. Legitimacy can also be increased because you have everyday citizens, because you have community members and healthcare workers involved in the consensus building process. It can help increase political trust or confidence in the policies from all stakeholders, because they are involved in developing them themselves. And also because they're developing them themselves, they're more likely to be accepted and implemented. Next, please. So our expectations was that we felt that policymakers would be more inspired to take action when they were aware of the community needs, because the community has been able to express their needs themselves, and also that the community would then have knowledge about the solutions to tackle healthcare access issues such as medical deserts. So we felt that through the consensus building process, by involving diverse stakeholders, by having a participatory process, and also being able to unveil our needs, we would be able to co-create policy options because of an increased awareness and learning from all stakeholders, which can also lead to shifts in power, knowledge, and interest on the issue of medical deserts. And then the outcome being that this could help counteract and prevent medical deserts through, as well as help with ownership of policy ideas, empowering citizens, increasing trust, and also taking a different course of action to the norm. Next, please. So I've spoken a lot about involving stakeholders, and there will be a lot of discussion about involving stakeholders today, because that really is the crux of what we were trying to do with this participatory consensus building process. So for the AHEAD project, effective stakeholder management was crucial. And what this involved from the beginning was a proper mapping and analysis of the potential actors and stakeholders that could be involved in this issue of medical deserts. And not just in terms of who they are, but also things such as what their interest in the issue might be, the amount of power that they hold within these processes. And what was required of our 5 different country locations was to really take stock of who they thought within their own context, within their own locality, would be a relevant party to consider for involvement in consensus building, but also just in the issue of medical deserts themselves. Also, I think it's very important to emphasize that stakeholder engagement is not and should not be a once-off event. What often happens in policy development is that local community members or stakeholders that are non-political stakeholders might be consulted further down the line once policy has been developed. We found it was really important to take that discourse and to take that common way of doing things, and to rather focus on how policy can be developed from the ground up. So involving multiple stakeholders from the beginning of the design, as well as providing constant feedback on the progress of this consensus building sessions. So it was really iterative and involved a lot of feedback and a lot of communication between multiple stakeholders. Next, please. Again, talking about the stakeholders, so who were these stakeholders? So we decided to have a look at organizations and individuals who could either have an interest in access to health services because they are maybe affected by medical deserts, or involved in healthcare provision, and or people who have an active or passive influence on the decision-making and implementation process. And we really aim to especially involve underrepresented groups, so those groups who are usually not given a voice in these spaces, so those who are most likely to experience health inequities for reasons such as barriers to access of health services. So this essentially resulted in us kind of categorizing stakeholders into three main groups. One being health recipients, so for example, community members or patient organizations. The other being health providers, such as your health workers, health worker organizations, and health insurers. And then lastly, the decision makers themselves. So this was both local government and also government at a regional, even national level. Next, please. And again, as I've said before, what besides stakeholder involvement was really important to us is that we very strongly felt as a consortium that whatever we did had to be context-based. So the consensus building methods that were developed aim to achieve joint development of contextually relevant policy options. So we very much so rebuked the idea that there can be a one-size-fits-all solution. We felt that there could be templates which could be followed, but these really needed to be tailored per country based on the stakeholders that were identified, the stakeholder mapping, as well as the contextual analysis of the health landscape. So, for example, what the healthcare system looked like, what the social, political, and economic status of the different localities we were working in were. And that required a lot of collaboration throughout the consortium for different country teams to really focus on what was necessary for their locality. Also, with doing this, the AHEAD consortium partners and local facilitators were in essence trained in order to facilitate the sessions in their countries. So there was a generic template for a session outline and a facilitator manual that were created. However, again, these were tailored with collaboration with the consortium partners as well as with the facilitators on the ground in these different locations to ensure that these sessions and also the facilitation style really reflected the needs and the tone of the different contexts in which these sessions were taking place. I hope I haven't lost you so far. I do tend to speak a little quickly, but if we are all still okay, we can move forward. So what did these sessions actually look like in a practical manner of speaking? We decided that the consensus building approach needed to be step by step because of issues of power and the fact that we were bringing together stakeholders who likely hadn't been in the same room discussing these issues before. We really wanted to pay due diligence to the fact that we were aware that you can't immediately bring different stakeholders from different sectors of society together and expect everyone to feel welcome and feel like they can actively contribute. So we decided to break down the process into smaller steps. So we started with local single stakeholder sessions where we had 2 or 3 separate groups of what we called homogeneous participants. So these being the groups I mentioned before, so health recipients, health providers, and decision makers. So within these individual groups of people who came from similar sectors of society, the aim was to focus on validating the identified problem of the medical desert. So why their area was a medical desert, what their experiences with this were, and also to brainstorm some preliminary solutions. Once the individual groups had come up with potential solutions for addressing medical deserts, representatives from these different groups came together in what we called our local multi-stakeholder sessions. These were once-off groups, usually. Obviously, this was able to change based off of the different contexts because different contexts had different needs. But essentially the idea was to have a representative or two from each homogeneous group come together, present the ideas that they had come up with in order to focus on needs integration and joint problem solving in order to find some consensus on different policy options that could be presented. And these were then to be presented at a national level session where the representatives who had been involved in the previous two sessions came together with political decision makers in order to try and codify the policy options from the previous phases. The idea is that because the participants had already been so involved in this process, they had really become quite immersed and meshed into this idea of policy development and medical deserts and really articulating their needs and wants and wishes, that they would feel a sense of empowerment going forward into these political sessions at the national level. Next slide, please. So each session followed quite a similar generic structure that focused on both exploring and coming together. So at first, the idea in each session was to introduce and clarify the options. So allowing the participants to get to know each other, explaining the agenda, outlining why we were looking at medical deserts in the first place, explaining why that location had been identified, etc. We then aimed to open out the discussion by exploring the stakeholders' experiences of living in a medical desert. So why did they feel health access was important to them? What were their perceptions of lack of health access in their area? Here they could share their experiences, their needs and opinions without having to rush into decision making. Next slide, please. We then tried to use different elicitation activities. So we had a few different activities we used to develop ideas for policy options that allowed all stakeholders to try and have a space to have their voices heard, whilst also weighing up pros and cons as well as feasibility. Before starting to come together by finding a common ground, establishing which options could be the most appealing and which options could maybe be combined. Maybe different groups came up with different ideas that were actually quite similar and how those could be combined to have a more feasible option. And then lastly, coming to some sort of a consensus where we would use voting methods, for example, to check that the proposals reflected the thoughts of the participants as a broader group. Next, please. So although the consensus building sessions did follow a similar structure, it's really important to emphasize that they all had different objectives and that each session was different depending on the context in which they were conducted in. So again, the objectives were quite simple. So for the single stakeholder sessions being to develop and prioritize a menu of feasible policy options. These should have been allowed to have been creative options within basic scopes and parameters. The local multi-stakeholder sessions were then to look at the options from the single stakeholders meetings and further narrow them down to presentable options in order to then in the national sessions be prepared and streamlined for use in policy dialogues, which will also be explored later. I think that this is the last slide, the next one potentially. Yeah, so I think in sum, the most important thing that I really want to get across from our consensus building approach is that we believe very strongly in the ideas of participation for policy making, and that needs to be something that involves multiple stakeholders from the beginning in multiple rounds of feedback. It's a really iterative process and it's not a one-size-fits-all solution. So we really want to emphasize how important context is within the development of our consensus building sessions. I hope this gave a very brief but clear summary of what we were trying to do within these sessions. And I would now like to hand back to Abdul for some discussion. Thank you so much.
Thank you, Ziz. Our participants, if you have any questions, comments, please continue to write. We will come back to you soon. Now, I would like to invite our panelists to have a discussion about our experience in deploying using this consensus building methodology. So we have Corinne from Wemos, we have Sergio from Moldova, Bianca from Italy, Julia from Romania. So I will post some questions and then maybe we'll try to have some discussion. So as from Jay's presentation, we know that one of the main objective of AHEAD's participatory consensus building methodology is to bring important and diverse group of stakeholders together and engage them in a sort of joint problem solving expedition and address the issue or concern of medical desert. But this is not a very easy task. So I would like to know, let me first go to Corinne. What has been your experience in using this consensus building methodology in your country context?
Yes, thank you, Abdul. Let me check first. Can you hear me okay?
Yes. Yes.
Okay, because I had an unfortunate incident involving a keyboard and a glass of water earlier on, but good that all is well. Yeah, our experiences with the consensus building, it's been quite a ride, very interesting. We had a lot of advantage of having the detailed methodology and a good training, of course. And it's been quite a puzzle to get the people around the table, but we've managed okay. And that is because we took a two-pronged approach, because of course what we did, and this was also in the methodology of the AHEAD project, you make quite an elaborate stakeholder mapping. So you already have an idea of who is who, not only in the health professionals field, but also elderly organizations, patients organizations, people from the municipality or the municipal council. And the other strategy was we looked at media reports. So articles, radio features and stuff like that. And then we could identify a couple of individuals as well. For example, individuals who had been affected personally by this problem of medical desertification. So bringing those two strategies together gave us a clear picture of who is who and gave us, you know, the starting points to reach out to individuals and engage with them. And from that on, we also had a snowballing technique that helped us really well. So yes, in the end, we were very happy with the people we had around the table. Yeah, thank you.
Thank you. Thank you. It sounds interesting, but I would also like to go to Sergio. What has been your experience in Moldova?
Yes, thank you, Abdul. Indeed, the scenario and the methodology that Corinne shared with us today is the perfect scenario. You know, the goal that was set for each partner to achieve when performing this local level consensus building exercise. But the beauty of the AHEAD project is that we were also allowed to explore the best options in regarding to the national context. So for Republic of Moldova, in this way, we were allowed to invite only health providers and decision makers to our local level consensus building exercise dialogues. But during the discussions, we tried to ask them what is in their opinion was the requirements and the questions, the solutions that a patient representative was trying to provide to us also. So in the end, this method ensured that the discussion were open, were focused only on the topic, and in the end it generated, in our opinion, the best possible results and the possible matter of solutions and recommendations that we can use afterwards. Thanks.
Thank you. Yeah, this brings me to the question of power dynamics. Even within the group, there are a lot of power dynamics. But before I go into that question, I would like to introduce another panelist, Stefan. Stefan is a assistant professor. He's from Serbia. So my next question is, as I was talking about power dynamics and a power imbalance, this can pose a serious threat to successful participation, successful implementation of participatory decision-making tools, especially when we are bringing in people with different level of power. So I would like to go to Yulia. what has been your experience in Romania? How did you bring different kind of people in the same table and have the discussion using this method? If you can share your experience, please.
Thank you for the question, Abdul. So I believe for the case of Romania, the AHEAD consensus building methodology provided a very suitable instrument through which effective and contextually relevant policy options were developed. And through its structure, the methodology offered the participants equal opportunity to share, discuss, and negotiate their interests. Overall, we noticed that everyone's views and needs were taken into account when engaging in the discussions, and there was balance between expertise and contextual knowledge. And the reason why we think the methodology was so successful is due to the structure it proposed, as each session had an essential role for the elaboration of the final policy menu developed, as Jessica was saying. In this sense, the first homogeneous session allowed the locals of the community to question what are the main problems with regards to access to medical services in their community, and really got them thinking about what they can do. And it was very interesting to see the change in perspective of the participants throughout the session. Because at the beginning, the participants were quite reluctant that this type of intervention can be effective. They had accepted that access to medical services is quite limited in their community, and that not much can actually be done. And they actually strongly believe that change is not in their hands, and change must and can only be exerted from the top. However, by the end of the session, participants really felt empowered to be involved in the decision-making process. They looked satisfied with the policies they proposed and left with a feeling of pride and even content with what they developed. Then we had the multi-stakeholder sessions, which allowed the newly empowered locals to really express their needs and to voice the solutions they think are needed in the locality in order to improve access. The session was very interactive and inclusive, and local and regional authorities learned and understood the needs in the locality and really adapted their proposed policies after discussing with the locals. One could sense some slight tensions between regional and local authorities regarding who is responsible for the provision of certain services, but they came to understand each other better and to appreciate each other's interests. And the session actually ended with opportunities for future collaborations to enhance access to medical services. And finally, the national session really showed how holistic the consensus building process is. The presence and discourse of the locals and the local authorities was really essential for the policymakers, as they gave proper attention to the case of the locality. While at the beginning of the session, the policymakers positioned themselves as experts, through further discussions and through the exchange of knowledge and expertise and experiences, they realized that the locals are the equal collaborators. And finally, just as an observation, we noticed that the previous sessions really prepared the stakeholders to advocate for their needs, and their contributions managed to generate a shift in perspective of policymakers from thinking of country-specific solutions to local-specific solutions, which was also reflected in the tailored policy options proposed. Thank you.
Thank you. You talk about the community people getting empowered. In participatory research tool, we often say that the process becomes intervention. So if I can now go to Stephen and ask him about sharing our experience, especially our methodology, try to empower the local community, trying to giving voice to the local community, especially those who have limited access to the power, limited access in the decision-making process. So especially in case of health policy making, what has been your reflection, your kind of experience while working on this project, Stephen?
Thank you, Abdul, and thank you for the opportunity first to participate in this project, and then also to share our experience working with the local community. As it was explained at the beginning, the methodology really allowed us to first show to the local community how we arrived to the conclusion, or maybe to the evaluation, that there is increased risk of medical desertification, and to share with them these findings, which actually come from their own words, from their own understanding of what medical deserts are. what is really unusual for the local communities with which we worked is that they are given a chance to propose some solutions, to maybe exchange opinions and even stronger discussions with the policymakers in their local community, with the doctors in their local community. And this was really interesting to watch and to be part of, especially because just as you know, our experience was you had people who are patients who are very often unsatisfied with what kind of medical care they are given, but their unsatisfaction is rarely compared or discussed with their healthcare providers. And this project allowed them to do this. When we talk directly about medical deserts, they could really explain what their needs are. And sometimes this kind of unsatisfaction actually doesn't come from any kind of problem with the provision of healthcare. It comes from other aspects that are not related to the healthcare providers, to the medical doctors. It was also important to have this kind of triangle between healthcare providers, patients and users, and policymakers, because everyone could hear the worries and the problems that each other have. But on the other hand, what often happens is that patients are in the position of lower power. But since we had the sessions which are together to exchange opinions, and then sessions which were separated, so they could discuss among themselves and set priorities for themselves, then it's also easier for them to defend the priorities. And we were at the end, when you look at these three very diverse groups, both within and between them, you could see that at the end, everyone in a way identifies the same priorities, identifies the same problems, and even very similar solutions. So this is a good way forward when we think about what could be done to address medical deserts, which is the point of our project. Thank you very much for this opportunity.
Thank you for sharing your experience, your reflection on this. Now we all did this exercise. We spent huge energy and effort to undertake all these activities in different layers and bringing all these people together. And the purpose was to, get some policy options. So if I can again go back to Sergio and I can ask you, so what has been this policy options? If you can share some of the most important and significant policy options you have received through this process.
Yes, sure. The medical desert phenomenon is really a hot topic nowadays to discuss upon. But to search for solutions, to generate ideas and concrete policy options is more complicated than first thought before the beginning of the project. I know that every partner of the AHEAD project generated more than a dozen of solutions each. And I think even more recommendations and ideas how to mitigate the medical desert and the desertification process in each country. But do they all fit at national level? Maybe at regional, but what about the European Union level? It is still an open question, because it was also very interesting and exciting to see how these local level solutions and recommendations transformed during the discussions. Afterwards, during the multi-stakeholder and national stakeholder discussions, also they, in a way, shifted, maybe adapted, a little bit changed according to eligibility criteria, and maybe to give them more chance to be transformed into a real policy option and a real law, for example, at national level on how to mitigate the phenomenon. I can give an example. For example, in our discussions, participants asked for significant increase in wages. Others wanted better working conditions and maybe a little bit shorter working hours for them. Anyways, a couple of participants also changed the division of national stakeholders and maybe demand more support in matters of mental health, of burnout issues. You know, having to work in a medical desert sometimes is more extenuating and more difficult for a doctor, and compared to maybe a well-equipped and a working job in a bigger country. Indeed, there were plenty of policy options that the AHEAD project is almost ready to present, but I will not give away too much because we will have a separate webinar maybe next month on this topic, and we will share the majority of policy options generated, also the systematic view on them, and maybe a little bit ahead of time, but we will share also the country notes and maybe ready to use policy options for other participants and other countries that they could explore and implement in their country. So stay with us, subscribe to the AHEAD project newsletter, and also please feel free to ask questions in the Q&A section that we will be happy to answer afterwards. Thanks.
Thank you, Sergio. Yes, of course, we'll have another webinar that will mostly focus on these policy options which we are getting from different countries, from this partner countries. Especially on this policy options, we'll have another webinar. We will send you the details. You can register and join that session as well. So now, like if you look at in a very logical order, that through these processes, we're getting these important policy options involving wide range of stakeholders with various backgrounds, power structure. But when we have all these policy options, what we do with these policy options, how these policy options are going to transformed into actions, into real change. So now if I can go to Bianca, so please enlighten us how this will be taken forward.
Thank you very much, Abdul. And well, as has already been anticipated by the other colleagues, the activities that we have been conducting in the recent months have led to the formulation, both at the local level first and then at the national level, of a set of concrete and feasible proposals aimed at counteracting the phenomenon of medical desertification. And the set of these national policy options will be then presented during a European event to be held in the spring at the European Parliament in Brussels, with the aim of providing all the relevant information and asking for concrete commitments to be made by policymakers who have the power to act in the fight against medical desertification. And about this, I would like to share with you an anecdote, because just a few days ago, I met with a member of the European Parliament who asked me what the European institutions could do about this situation, given that the major decisions about health are made directly by the single member states. And well, my answer was simple and clear, because actually the European institutions, and especially the European Parliament, are made up of politicians who have also a role and the influence at the national level, and who therefore can work on these causes. And that's why we think it is important that they also get involved and increase their awareness toward the phenomenon of medical desertification.
Thank you. Thank you so much. In fact, thank you to all of our panelists. It has been a very nice experience hearing from all of you. Now, the next part of the webinar is to answer the questions of our participants. I have seen they're very, very interesting, some of the questions. So I will try to take some of those questions. So the first question we receive is, I don't know whether I can pronounce the name correctly. It's if like being Indian, if I pronounce it like Isato Sir. The question is certain geographic locations, primarily rural and hard to reach areas like mountains, isolated regions, as well as communities primarily inhabited by vulnerable minority populations are particularly affected. At least, not least because health workers are gravitating towards bigger cities and increasingly to other countries to access better career opportunities. So here we have like different layers of problems, both the issues of geographical inequalities, peculiarities, and also political problems, context-based problems like minority-related issues, and then again the issue of health workforce. If I can, but you can like pass the question to another colleague as well. But first, I would like to go to Corinne. If you can share your reflections, especially on this, especially related to health workforce, how this health professionals are moving to urban areas or even to other countries for better career options, but that is creating some sort of challenges or helping increase this problem or phenomenon of medical desertification in Europe.
Yes, thank you, Abdul. I certainly can. I find this intervention, well, I'm totally agree with Isa too. Really, it's more of a comment than a question, but it's the nail on the head. I mean, what's happening in very localized areas that we call medical deserts is the micro version of what's happening at macro level, national, between nations, between the countries in the European Union, especially in the free labor market, of course, of the European Union. So that's why I was also quite excited to hear Bianca about this MEP, who then asks, well, what can we do? Well, you can do a lot, because if you assume the responsibility to address this between the member states, then you can make things happen also within the national contexts. So not only between the member states, but also in the national context. I could say a lot more about that, but let's not do that, because there are a couple of other questions also in the chat. There is also, by the way, Abdul, there's also still a question in the answered section of the Q&A. Did you see that? Thank you. Yeah.
Yes. Yeah. So. Yes, now let me go to that question. So that's a very detailed question. My colleague Jess would be, I think, best to answer this question, especially on involving various groups, patients. Should I read out the question, or Jess, you can see the question?
I can see the question and I can read it out. I think in terms of my experiences, I'm going to take the second one that looks at power, and I would like to leave the other two open to any of my colleagues to jump in on. But I think the question about power imbalances between stakeholders, and also again, I'm really sorry if I pronounce your name incorrectly, but I will go with Associate Professor de Wilt. says that often the most powerful actors are the ones that are holding the purse strings, whether it is insurers or national or local government through universal state health services, etc. How is this negotiated? I think the first thing to acknowledge is that power is present. And there are different forms of power, whether it be power as reward, expert power, coercive power, referent power. There are power dynamics that are at play in any kind of space. And so the first thing we wanted to do was to acknowledge that all different forms of power were valid, because even though those who tend to be seen to have the most power in these situations because they are the most, they have the economic power, there are other forms of power that we wanted to acknowledge too. So social power within a community, for example, and also these more inherent types of power. So the first step for us was to acknowledge and understand what power existed, because these different types of power dynamics are actually quite often hidden. And we wanted to take a moment to bring those to light. So to do this, we took a more triangulated approach where, so for example, Corinne already mentioned the media analyses. So looking at media, asking stakeholders what their perceptions of their own interest in, and influence on a situation was, asking other stakeholders what their perceived interest of other groups were, and also through our own experiences of working within these contexts and within these, for example, ministries or with these different stakeholders. For us, it was important to do this beforehand, because by understanding the potential power dynamics that might come up in the sessions, you can try and mitigate them before through the development of the methodology. So we really tried to then develop a methodology that was created in a way that can more inherently address power. So having activities where those who usually have the loudest voice are almost rendered slightly incapable of dominating the space because of how the session is structured. And I think Julia gave a really nice summary of how that worked really well in their context. So I hope I kind of get to the point of the question, but for us, it was understanding the power beforehand so that the methodology could be developed in a way to try and mitigate that more passively. Yeah, obviously it's never a perfect solution, but in a lot of cases it worked quite well. I hope that answers your question.
Thank you. Thank you. So Professor's questions, we are addressing it from different panelists. So first part of the question is involvement of groups, patients who struggle most to access, most with access. How do you actually do this through chosen representative or advocates? Or I'm sorry.
Bless you.
Okay, so this part, the additional targeted qualitative approaches, in-depth interviews and focus groups. Maybe Corinne, again, I will come back to you. You would be good choice to answer this.
Yes, it's a very good question, because it's actually one that we struggled a bit with as well. Excuse me as well. Because you, excuse me. What we did is we identified a couple of groups of representing patients, but also, for example, the elderly organizations. We had a case study area where we also have an aging population, and luckily for us, they are quite well organized. So that was a good entry point. So they could be seen as representative. We also included and invited, and she participated, a chronic patient that we had identified through the media analysis. So she's not representing chronic patients as such, but she has a story and an experience that is relevant. And I mean, she was very vocal. She was very, her expertise, her experience was respected and acknowledged and taken very seriously. It's important to understand, I think, that the approach that we used, the consensus building methodology, is not what you would call a citizen council. That is also going on in a couple of countries in Europe, because that's a much more extensive and time-consuming process. So this is a question that we also had when we started engaging with national level policy makers or duty bearers. They said, like, yeah, but how representative are these people that you have spoken with? Is it like a citizen council? Well, I could not say that it was like a citizen council that we really captured all the experiences and angles to the problem. You know, that was possible. That was just not possible in this period of time. But we do feel that we have sort of a 360-degree input anyway. Yeah, thank you.
Thank you. Sorry, once again. I came from India, and now here is this weather. So yeah, I'm struggling a bit. So the third part of the question is again a very important and interesting part, is question of legality, but also Professor has clarified that it's related to trust. So if I can go to Sergio, what has been your experience, and if you can yeah, throw some light on this.
Well, yes, indeed, there is a problem of legality, of trust of the policies, options, and recommendations that are gathered from lower level or for the patient's perspective. But indeed, the main deliverables of the project is to propose, not to impose a methodology. And also, we just want to have like a set of recommendations of policy options that are not mainly fit for all countries in European Union, but mostly the country experience on dealing with the medical deserts. We really hope to have like the Ahead 2 project maybe, in which we will explore what are the chances of this national level policy options to be EU level accepted, and what will be the power balance between bigger countries and maybe smaller countries like Moldova in promoting, accepting, and adapting the recommendation and the solutions that we will generate for the methodology. Local level consensus building exercises could generate in each country. And we really understand that the solutions are not universal, and they in one country may work, in another may need some adjustments. But there is still plenty of work to do, and we hope to keep the team and have the continuation of our work, and maybe think bigger, not at country level, but a European level and the regional level, maybe global level, maybe. So I think it's quite a lot of work to do on the medical desert subject. And also I would like to answer the question about burnout that we dealt with in Moldova. I mention it because burnout, mental health issues, it's really an emerging question in our country. Not all, I would say, rather less than expected of medical doctors and health professionals understand the issue of mental health difficulties and burnout syndrome in the health workforce. So when we try to state what are the symptoms of burnout, almost everyone noticed that is about them, but they did not understand that it was a burnout, or maybe they will need like a break. In the end, we see that the burnout may lead to malpractice, maybe medical errors, and maybe absence from work, or in the end, the patient will suffer. So burnout is really an emerging topic in our country, and we still need to learn how to deal with it and spread the knowledge on it in our health workforce. Thanks.
Thank you, Sergio. I see another question from Borwan. Corinne has answered a written answer, but I request other participants to go through the answer. But I want to request Bianca, what is your perspective on this? On Borwan's question, if I can read out the questions, it might be helpful. From our work with marginalized groups and in communities with lack of health staff, we are often facing with the problem that people are often reluctant to openly speak about dissatisfaction of the health services and to demand improved health services from the health providers. Even when their rights are violated, they rarely file complaints. This is mainly due to the fact that they will confront the only available healthcare provider, and afterwards, again, they will depend on him or her for obtaining healthcare. Have you faced these issues, and how did you address them? Bianca.
Well, of course, I can mainly speak about the Italian context. And actually, in my experience, in Italy, the situation is a bit different, if not quite the opposite, because people do complain. And actually, of course, we're happy about it because, of course, this means that there's space for change, or at least people is empowered enough to know how to speak with their own voice. At the same time, I have to say that I'm pretty proud to work for an association who deal with this kind of issues and help citizens and patients to be more empowered and to use their own voice. And so I have to say that in this context is quite important to refer to civic associations and patient associations at the national level. And of course, if needed, also at the European level, because their work is very important and from this point of view.
Thank you. This is the last minute I have. I again thank you all for your valuable inputs and discussion. I also I'm very, very thankful to our participants, especially for the questions, very brilliant questions, thought-provoking questions. I again invite you all to our next webinar. We will send you the invitation link, registration link, and other details. So with these words, I conclude this webinar. Thank you very much.